Hi everyone, this is Molly Lombardi. I am going to be going over the content for the gastrointestinal system and disorders that are associated with it. This is the first of 4 PowerPoint slides. I have divided them up to help everyone stay organized and have easier comprehension of the content. If you guys have any questions, please feel free to email me or stop by my office at any time. In this presentation, we're going to be going over the general anatomy and physiology of the GI system. Then we're going to head over to assessments for both subjective and objective data. We're going to check out some diagnostic studies for the GI system. We're going to talk about parenteral nutrition, both TPN and PPN. And then we're going to finish up with central venous access devices, the different types, and the nursing care that's associated with them. So first we're going to go over a little anatomy and physiology, and this is solely to help you understand the GI system, and this is kind of like a foundational stepping block, a little review. So the GI tract, it's composed of the mouth, esophagus, stomach, small intestine, large intestine, rectum, and anus. And you can see on the picture on the left-hand side where all of these different parts of the tract align. There's also associated organs that are listed in your text. We aren't going to go over this right now, and you don't need to read on these. And this is for the liver, pancreas, and gallbladder, because they're going to be addressed in other classes. So right now we're just going to concentrate on the GI tract from mouth to anus. There are 4 functions of the GI system, and the disorders that are going to be presented in this lecture are going to fall under one of the 4 functions. The first function is ingestion, and this is how we bring food into the body. So when we get into disorders like cleft lip and cleft palate later on, we're going to see that they're examples of ingestion problems. Next is digestion, and this is how the body breaks down food. This begins in the mouth, and that's with the teeth and saliva starting to prepare the food, and then it goes into the stomach, and this is where the gastric acid further breaks down the food. Then it's going to go to the small intestine where the majority of absorption will take place, and absorption is our 3rd function listed here on the slide. Finally is elimination, and this is where the body excretes the waste products that weren't important to be absorbed in the body. It's also important to know that the GI tract, it's controlled by the parasympathetic and sympathetic nervous system. And a very large percentage of cardiac output is dedicated to the GI tract. And so in situations where there's stress or injury, or when someone's performing heavy exercise, the blood can be shunted away from the GI tract where the body is going to need it more at that moment. So if you guys can all remember back to the stress and crisis lecture, we briefly discussed this in the fight or flight section. So hypo or no bowel sounds during extreme stress are present, and this is why, because the blood's being shunted elsewhere. The abdominal organs, they're covered by a lining called the peritoneal, and there are 2 layers within the peritoneal. The parietal layer that lines the cavity, and the visceral layer that covers the organs. So when you guys are in clinical, or maybe when you're practicing independently, if you see a dehisced wound, you might be able to see the organs through the visceral layer, and it's very interesting to see. An important role of the nurse is assessment, and we all know this. So we're going to start here. First, we want to collect subjective data, and again, that's from our client because it's subjective, and we can do that adequately through a good health history. We first want to start to ask our clients who are having GI concerns, do they take any medications? And this is because often medications can contribute to GI problems. We want to be sure to know, in addition to the prescription medications, do they take any over-the-counter meds or herbal supplements? because often these medications too can have an adverse effect on the GI system. In particular, if they take any NSAIDs or non-steroidal anti-inflammatory drugs. Examples of an NSAID could be aspirin or ibuprofen, also known as Advil or Motrin, or naproxen, also known as Aleve. The NSAIDs can predispose a client to GI bleeding, so that's why it's important for us to know if they're taking them and how often. If they are or recently taking antibiotics, we want to know it, and this is because the antibiotics are used to destroy a particular bacteria, but it also destroys healthy flora in the GI tract, and this can lead to C. diff. You also want to specifically know if they're taking any laxatives or antacids. And the reason why this is important, if they're having an absorption problem, the laxatives and antacids interfere with absorption. So this could be a key bit of information. Next, we want to know if they've had any GI surgery. Any change in the physiology of the GI tract could affect the functioning. Their weight, their diet, nutritional intake, or food allergies, we would want to know, specifically food allergies, because this can be considered an irritant. You want to know if they've traveled abroad. Perhaps they came home with nausea, vomiting, and diarrhea because they picked something up along the way. So you specifically want to ask if they've had any recent travel. You want to know their habits, and when I talk about habits, I'm thinking of the more smoking and drinking alcohol habits. And this is because it can irritate the gastric and mucosal lining of the GI tract. Is there a family history with GI issues? And when we talk about the inflammatory bowel disease later, we will see that there's a bit of genetic link there. So that's why this is important to know. You want to know what their normal elimination pattern is. Some people move their bowels 3 times a day, while others move them every 3rd day. So it's important to know the information that they're telling you, if it's within their normal range or not. You also want to be sure to think about culture, perception, and values of the client. And these can affect their diet, their lifestyle habits, and their attitudes about their own health. And this will ultimately affect your plan of care with them, which is why it's important to take into consideration. You'll see I have a picture of an elderly couple on the right-hand side of the slide, and I use this a couple different times throughout this lecture content. When you see this picture, I want you to think about the gerontological concerns. So when we're doing the assessment and health history, what I'm talking about with the elderly population is to think about the concerns related to the slide. So right now we have to think about the decreased appetite that may be happening for a number of reasons. They may have a decline in taste buds, which is normal progression. They will also have less saliva, which can lead to a dry mouth, and will decrease their nutritional intake. Other physical changes that often occur are the loss of teeth and decreased motility, and that leads to decreased GI mobility and motility. So changes in their ability to secrete gastric acids to break down food also occur. And they tend to have a prevalence in constipation because of these different aspects. So when you have an elderly client, you would do an abdominal assessment and pay close attention to their peristalsis, or the movement of their bowels, by listening to the bowel sounds. You would be considerate of any inactivity and decreased fluid and fiber intake, which is again common in the elderly. Also, to pay extra close attention to the medications they're taking, because often polypharmacy is prevalent in the elderly clients. So you would want to make sure that the medications they're taking are absolutely necessary, and if they contribute to the GI symptoms that they might have. In your text listed on the slide, I have identified a table that I want you to pay attention to. It's a nice chart on the gerontological assessment differences, and you're going to want to take a close look at this text page. Now we're moving on to the physical assessment after our history has been collected to get our objective data. And we want to take a look at 3 focused areas: the mouth, the abdomen, and the rectum and anus. So starting with the mouth, we want to assess things like the odor, if there's any odor to the breath, what the oral mucosa membrane looks like, if there are any lesions or changes in color, the teeth, if they are present or loose or broken, and also the tonsils, which would be the size and appearance of them. With an infant, we want to inspect the lip and the palate to make sure that they're closed. Now, when we're moving on to the abdomen, you want to, obviously you know that there are 4 quadrants that we divide the abdomen into when assessing. And you're going to want to position your client in a supine position or on their back, with their knees slightly flexed and their head slightly elevated. And this is to relax their abdominal muscles so you can assess better. You first want to inspect. So you look at the symmetry. Is everything the same on both sides? You're going to look for the contour. Is the abdomen flat, round? Is it distended? Are there any masses that you can see or pulsations that you can see? Then you're going to move on to auscultation, and you're going to use first the diaphragm of the stethoscope to hear the high-pitched gurgling bowel sounds. You want to listen for 2 to 5 minutes to assess for hyperactive or hypoactive bowel sounds. And if you don't hear any bowel sounds, you need to make sure you're listening for the full 5 minutes before you consider it to be absent bowel sounds. And then you will document what you find. You can also listen with the bell of your stethoscope for vascular sounds. And I'm talking about either renal or aorta bruits that can be heard through this. And usually it's a whooshing, low-pitched sound. And this could indicate that there's a cardiovascular problem going on. So next after this, you want to percuss. And you do this by tapping your 2 fingers over your other 2 fingers, which are on the patient's skin and on the abdomen. And you're going to hear either tympany or high-pitched bowel sounds, and this can indicate air. Or you might hear a dull sound, which would indicate maybe either a fluid is present or a mass. And then finally is gentle palpation, and this is done, again, to assess for any masses or swelling, but also for tenderness when you're palpating, or rebound tenderness, which is when you are done pressing, you release the pressure and it might hurt after you release the pressure. That's called rebound tenderness. And then you can also assess the rectum and the anus to see if there are any abnormalities, such as any fissures, which are a small tear in the lining of the anus, if there's a rash that's present. If there are hemorrhoids, which are swollen and inflamed veins in the rectum and the anus, and this causes discomfort and bleeding. You may do a digital exam and feel for any nodules or tenderness, and you may take a stool sample for guaiac or occult blood in the stool during that procedure. Let's now look at some diagnostic studies. So these will follow through the entire unit of gastrointestinal issues. There's a nice chart in your book that I highlighted on your slide. This is about 3 pages long. So what I've done is I've taken the information from that chart to kind of focus on what I feel is really important. So remember that with all diagnostic procedures, your role as the nurse is to provide education to the patients. You should be telling them what they can expect during the procedures. And you also want to make sure that if they need consent, that you're responsible for like witnessing it and making sure that the client's well informed for the procedure. So starting with the upper GI series with a small bowel follow through. This is usually done with contrast or barium, which is typically used. What happens is the client drinks the barium ahead of time, and then they go for a series of x-rays, and that's going to look at the GI tract and follow the barium as it goes through the system. So the barium will show up on the x-ray as white, and it allows for easy visualization of the path, and it tells people how long it takes for certain things to pass through a specific area. And then when we get into like the peptic ulcer disease, this is the most important test for this, and we're going to discuss it again. The lower GI series is also known as a barium enema, and this is done again with the barium contrast. The barium, it's instilled into the rectum via an enema, and again, the series of x-rays are done to look at the structure and function to see what's going on in the bowel. An endoscopy, it uses a lighted fiber optic instrument, and it goes down the client's throat. With this test, you can visualize the esophagus, the stomach, the duodenum, and also the colon. Next, there's a test called an endoscopic retrograde cholangio pancreatography, or an ERCP, which it's always called ERCP because that's quite a mouthful. This is where you have an endoscopy where they can remove stones. For example, they can remove like gallstones in the gallbladder. So a major complication with any endoscopy is perforation. So as you can imagine, a perforation in the GI tract can cause serious issues. To the right, there's a picture of an endoscopy, and if you click or double click on the picture, it'll lead you to a video of the procedure that you can watch. The next procedure is a colonoscopy or a sigmoidoscopy. The sigmoidoscopy is where the same type of fiber optic instrument is introduced through the rectum. And the sigmoidoscopy only shows the lower rectum, where the colonoscopy goes through the whole large bowel. And this test will be important later when we talk about the inflammatory bowel disease and diverticulosis. If you do the same type of clicking on the bottom picture, you're going to see a video for this as well. There's also something called a virtual colonoscopy, and this is done using a CAT scan or MRI technology to visualize the colon. An abdominal ultrasound or even a flat plate x-ray of the abdomen can show the structure or function issue that might be going on. An ultrasound, this is going to be used to diagnose intussusception. And then finally we have stool specimens, and this can be collected for stool cultures if you're specifically looking at an infectious cause or an organism that could be suspected. Or there's also the guaiac, as mentioned in the last slide, that can be used to test for blood in the stool. In some cases, clients cannot be fed through the GI tract either at all or enough to sustain life. So they are good candidates for something called parenteral nutrition. There is TPN, or total parenteral nutrition, which supplies the total amount of nutrition to the patient each day and is administered into the bloodstream, usually through a central venous access device instead of through the GI tract. There's also PPN, or peripheral parenteral nutrition, which is a lower concentration of the parenteral nutrition and can be administered through either a central venous access device or a peripheral line, which provides the client with a portion of nutrients needed each day. It is composed of dextrose, or sugar, amino acids for protein, and fat emulsion, also called lipids. There's also electrolytes and other trace elements and vitamins within TPN and PPN. TPN is usually administered if a client doesn't have the ability to ingest foods for an extended amount of time. This can be either temporary or lifelong. Indications for using TPN and PPN usually is when they need gut rest because they have a severe case of nausea, vomiting, or diarrhea that again is over an extended amount of time. An example is with pancreatitis, which requires gut rest for weeks at a time. Another indication could be surgery or trauma that renders the patient incapable of ingesting foods for weeks to months. There may be a malabsorption problem, and what I mean by this is that maybe the small intestines aren't able to absorb the nutrients properly, or there could be a case of short gut syndrome where there's only a very small amount remaining of the intestines, so they don't absorb the nutrients that they need to, and this is where PPN is usually used, and sometimes in severe cases, TPN. There could be an obstruction, so the blockage, if you will, the intestines aren't able to pass through food, so therefore nutrition isn't able to be absorbed. Complications of parenteral nutrition include infection. And this isn't surprising since it's often administered through a central line, which goes into the vena cava of the heart. So it's obviously important for the nurses to use sterile techniques with all central lines and when preparing the TPN. TPN is a solution that is very high in the dextrose concentration, and bacteria love to flourish in this concentration, this medium. There's also hyper and hypoglycemia that can occur with TPN. Commonly, TPN is administered over 24 hours without any breaks, but for one reason or another, if the supply is cut off abruptly, hypoglycemia can occur. If clients are on it for a shorter amount of time period, say over 18 hours a day, the TPN has to be either cycled up or down when stopping it, and this cycle has to happen gradually. It gradually increases and then decreases the amount of TPN being administered, and this avoids the swings of hyper and hypoglycemia. Blood glucose monitoring is common during these times, and some clients will even require insulin to manage episodes of hyperglycemia while they're on TPN. And finally, the last common complication could be catheter-related problems, which we're going to discuss next. There are both advantages and disadvantages to using a central venous access device. The first advantage is the ease of access once it is established, especially when you have a client who has poor vessels. It can be used with irritating solutions. In addition to the TPN, there are other solutions that are harsh on small vessels, but the vessel holds up just fine when it's larger, like what's used for a central venous access. Another advantage is that it is more long-term access, where a peripheral IV may only last a few days to a week. Depending on the type of central access, it can range from weeks to months to even years. Another advantage is that you're less likely to develop a phlebitis or infiltration with a central line. And then again, another one is that blood can easily be drawn off of a central venous access, so your patients or clients can avoid frequent needle pokes. The disadvantages: central lines are only inserted by trained nurses and providers. It's a more invasive procedure and it requires consent to be obtained. The dressing changes are done sterilely. There's a risk of a pneumothorax during insertion, dysrhythmias, and also air embolisms during the insertion and thereafter. Infection and sepsis, this is a huge disadvantage. More so than phlebitis or infiltration of a peripheral line, infection and sepsis is detrimental when we're talking about central venous access lines. And cost is another disadvantage. They are much more expensive than a peripheral line to both place and to maintain. There are a few different types of central venous access devices, or CVADs, as you'll see abbreviated in the charts. You're going to look at the different types in your SALT class this semester, but here's a little overview of the more common types. The first on the left-hand side of your screen is a Picc Line. This stands for Peripherally Inserted Central Catheter. This is usually placed in the arm and goes in the basilic or cephalic vein, and it's advanced into the superior vena cava. Again, the most common site is the arm, but it can also be placed in other locations. The picture on the top of it you can see is a real-life view of what it looks like on a patient. There's typically a small round blue disc at the insertion site called a biopatch that helps prevent bacteria from accumulating at the insertion site to reduce the incidences of infections. The Picc line is usually a middle of the line as far as length of time. It's weeks to months typically, and patients can go home with this. The right-hand side is an implanted port. These are surgically inserted and completely covered by the client's skin. You can see on the bottom picture what it looks like when it's not accessed. To access this, you have to use a specific needle type that punctures the skin and also the top membrane of the port. And then you use a tegaderm over top of it to hold it in place when it needs to be used. This is the longest type of access, the long term, and it's not used for short term. It has to be surgically removed when they're done. It's typically used frequently when patients undergo chemotherapy treatment. Continuing on with the different central venous access devices, on the left-hand side we have a tunneled catheter, which is when the catheter enters into the chest wall and they are tunneled under the skin and then enter the heart up top. There's less risk of infection than the non-tunneled catheter, and the placement is a bit more secured, and it's usually a little bit more long-term use than the untunneled. On the right-hand side is the untunneled catheter, and you can see it goes right into the vein itself, into the superior vena cava. Usually they are called triple lumen catheters and often have the 3 lumens. They are more short-term use than the tunneled catheter and also than the Picc line. Usually it's used only in hospital settings. The multiple catheters for both the tunneled and untunneled, they allow for various medications and blood products or TPN to all run at the same time, even if the solutions aren't compatible with each other, because the lumens release the medications or the products, whatever's going through it, in different holes along the catheter, which during your SALT class and during lecture, I'll show you what I mean by that. In terms of care for a client with a central venous access device, our priority action is to prevent infection. The Joint Commission, who accreditates hospitals, has set forth some recommendations in the form of national safety goals in terms of caring for Cvads. The first is hand hygiene, and this is number 1, and it goes back to preventing infection. The next is sterile dressings. When changing a Cvad dressing, it's usually done once a week, and it is a strict sterile procedure, and you can see this in your text on the spot I outlined. Antiseptic solutions such as chlorhexidine are used to scrub on the site of entry when you're going to hook anything up to it, whether a flush or medication. And the solution that's used, it depends on the facility policies, and this is something that is frequently changed based on research. Education is important. In this case, the nurses are usually the one who provide clients with education when they go home to use a Cvad. And it's also important for the nurses to be educated themselves about the importance of preventing infection and preventing complications. So both education for the nurses and the nurses to give any caregivers that are going to be taking responsibility for the Cvad. Wearing PPE, protective personal equipment. Gloves are always used when using a Cvad, and masks are also used by everyone in the room when a dressing change is being done on a central line to prevent the spread of bacteria. There's also barriers like the biopatch that I spoke about earlier, and also transparent dressings over top of the insertion sites. You want to make sure these sites are clean, dry, and intact, which means they're free from any peeling or tears. The monitoring of lines should be done at least daily, but ideally every shift, and this includes the length of insertion. Typically, this is documented in centimeters in the patient's chart, and it refers to the external length of the catheter. The nurse is assessing to see if there was any migration, either in or out, when they're assessing for placement. There's also a reason to assess for any signs of infection that you could see around the insertion site. This can be seen as any redness, swelling, tenderness, induration, or exudate. Does the client have a fever with no known cause? And typically, if an infection is identified in the Cvad, it's going to be removed to prevent sepsis. These are much different than a localized infection because remember, these go right into the heart. It's important to also remember to only use a 10 ml syringe when flushing and instilling medications for a Cvad. And this goes back to the size of the barrel and the pressure that you put on the Cvad. So the bigger the barrel, the less pressure. And that's why we must always remember to use a 10 ml syringe. So this concludes the section of the voiceover. And next we're going to go over GI disorders in the children.